This week it's my pleasure to introduce one of our own here, one of my three favorite local radiation oncologists, Joe Rhoades. Joe's going to delight us with a presentation on his fancy technology that he can use to help people with cancer get along a little bit better. And I think the focus is going to be palliation, but he'll have some new insights for us as well. And I'll go ahead and please welcome Joe Rhoades.
All right, can you hear me? Can you hear me in the back? Yeah, I can hear me now. Okay. Well, I want to talk today about some of the newer treatment paradigms that we're transitioning through in palliative radiation oncology. This is largely due to a vast improvement in our technology and our ability to quickly, rapidly, and accurately deliver radiation therapy, as well as some new clinical trials. In the last year, the hospital was gracious enough to update our radiation therapy linear accelerator with the Truebeam. It's the most advanced linear accelerator that's available currently. It's a magnificent piece of engineering and is clearly 21st century technology. Now, we got a whole group of folks to operate these machines. The radiation therapists are highly trained individuals that operate these computer-controlled machines and position the patient. So you basically have one person watching the patient, the other one watching the computer and the machine. And these are the three stooges, Mo, Larry, and Curly over there. But Dr. E, Dr. Hopkins is our newest member of the department, and then there's that handsome guy over there on the right. We have nurses to help assess our patients for acute side effects of radiation therapy, and then Deb DeBerkey is our scheduler out front who helps us schedule all the patients. Right now we're treating about 40 patients a day. We also have folks in treatment planning. As techniques in radiation therapy have become more complex, the CT simulations have become more complex. We have a light-speed CT simulator where we actually can CT during breathing on any tumor between the thoracic inlet and the pelvis to see, how much they're moving, so that we can track them during treatment. The computer planning for the delivery of radiation therapy is very, very complex, and takes, again, a whole another team to help to work these out. Brian is our medical physicist, our dosimetrists are Samantha and Sherry, and they work like the devil to get all this planning done, and so in short, it takes a whole team to deliver radiation safely and save my caboose. So today, I just wanted the objectives are to figure out what some of the options of palliative care. I want to introduce a new term called ablative stereotactic radiation therapy, where we give just a few treatments to ablate the cancer because there's such a low volume of normal tissue in the treatment field, and the use of injected intravenous radionuclides for the treatment of bone pain. And then there are new trials and a push to decrease tumor burden in patients with limited oligometastatic disease. And then just a short review on that, our traditional palliative regimens also work well. So why do we give radiation therapy for palliation? About 30% of what we do in the clinic is palliating some symptom or problem in order to provide a better quality of life. And so we relieve pain from bone metastases or cancer pain from invasion of sensitive structures. We can give radiation to prevent obstruction of an airway and collapse of a lung, or radiate a bone that's being that has some cortical destruction that has risk of bone fracture. And of course, one of the classics is the spinal cord compression. In selected patients with GYN and colorectal cancers, we can give short courses of radiation therapy to stop bleeding and, of course, to relieve neurologic symptoms. So traditionally we treat what hurts, what's going to break, what's going to obstruct, but now the more controversial reasons to give palliative radiation therapy is the concept of tumor debulking in patients with limited oligometastatic disease, and I'll go through that in a little more detail later on. So case one is a 69-year-old gentleman with hormone refractory metastatic prostate cancer. He has metastatic prostate cancer to the bones. He's had Lupron, and his PSA is rising and his bone scan has progressed. He started having pain. Some of it is localized, some of it's migrating. This shoulder hurts, that shoulder hurts, the back hurts, then my hip hurts. And this is a common problem that we see in gentlemen with hormone refractory prostate cancer. He's in good performance status and is on the fentanyl patch and hydrocodone for pain relief. And the goal of the radiation is to take his pain away and get him off the higher doses of opiates so that you don't have to deal with the side effects of the sedation, the nausea, the side effects of pain medications. We need to know that his CBC is relatively normal because everywhere, a lot of areas that we radiate can decrease bone marrow reserve, and we don't want to radiate it and compromise further therapies or make him transfusion dependent. So we get plain x-rays of the weight-bearing bones. You'll see his bone scan here in a moment. The reason for that is if he has cortical destruction, he may need an orthopedic consult to have a potentially morbid event of a fracture of a weight-bearing bone. And this is a typical bone scan of a patient with metastatic prostate cancer. Even though we see on the bone scan that there are multiple areas in the skeleton that are involved with bone metastases, they don't hurt everywhere, but at some point an area may break through, and those are the ones that we focally radiate with external beam. When patients have migrating pains, then we have to add another component of palliation using an intravenous radionuclide. Jiminy. All right. So this fella had plain x-rays. He did have, it was less than 33% cortical destruction on his x-rays. We asked the orthopedic surgeons to take a look, but he was medically not a good candidate for IM rotting, so the left femur was going to be an area that I would need to treat. We updated his CBC, and then he underwent planning and simulation to treat the painful area and the bilateral sacroiliac joints where he was localizing it focally, and that left femur to take the cancer away so the body can put down new bone and firm up that left femur. So the old palliative regimen for treating the sacroiliac joints is we would put them through 10 or 15 treatments over 2 to 3 weeks, Monday through Friday, traveling from Marshalltown in a snowstorm in a patient with metastatic disease. Doesn't sound like a heck of a lot of fun to me. But we have new clinical trials in palliation that have that have allowed us to decrease the number of treatments. The current recommendations, there are patients with just a few areas would receive 800 centigrade times 1. There are other folks with a little bit bulkier disease that we would treat with 400 centigrade times 5. So we've cut down that treatment time from 2 to 3 weeks to a week or even 1 day. We use more conformal fields so that we protect the bone marrow better. And, the medical oncologists are always pestering us, when is he going to get done? When is he going to get done? Because we got to start chemotherapy or that next new marvelous agent they have in their pocket. And so for folks with migrating pains or pains that just don't really localize to one area, we also give those folks an IV injection of a radioactive calcium mimetic. Right now we're using samarium, but we're really enthusiastic about the new kid on the block, radium-223. And the caveat here is that the bone mets have to be osteoblastic, and of course prostate cancer, most of those metastases are highly osteoblastic and would incorporate these calcium mimetics quite easily. Calcium, strontium, barium, and radium, and then below that is samarium, are all transition metals that act as calcium mimetics. In the old days, we used strontium. That had considerable permanent hematologic suppression of the bone marrow. Strontium has still some hematologic toxicity, and the new kid on the block has let me back up a minute. Samarium has about 60% transient depression of the white blood cell count and the platelet count about 3 weeks after injection. Radium, it's about 5% or less. And the reason for that is strontium had a bigger sphere of radioactivity, and as you go down the chart, and it has to do with the type of radiation that these radioactive nuclides demonstrate, but radium, we now believe, can deliver, about 6 cell widths, and it incorporates in the bone better than samarium and strontium. So it binds better, it penetrates a smaller distance, so there's less bone marrow exposed to radiation, and less than 5% had grade 1 or grade 2 hematologic toxicity in the clinical trials. This is kind of a cartoon to show that it's a spherical dose. Radium is an alpha emitter. It's an alpha particle which has much higher energy and more destructive power than a photon, say from samarium has a gamma and a beta emissions, and they have less energy transfer, or they're less effective at damaging the cancer cells. So the cool thing about radium is it's a smaller sphere, it doesn't expose the bone marrow, and it has a more effective particle to kill the cancer cells with. And it also lessens the radiation concerns. When we give samarium, we have to tell the patient, when you pee, you have to flush 3 times, and you have to stay away from, pregnant women and small children for about 48 hours. Radium is an alpha emitter and is very safe to be around, and it's excreted into the stool. So, and its penetration distance is so short and so small that there really aren't any significant radiation concerns. So it's on top of everything else, it's safer. And we all got excited because this was the first, radium-223 was the first radionuclide to demonstrate an improvement in overall survival. So it's effective as a therapeutic agent, not as well as decreasing pain. And we're all chomping at the bit to get the government to release radium-223. It's on the, unfortunately, they didn't get it on the fast track until December. So we're looking at least July or August before it's available. In the interim, we'll have to use use samarium. And the clinical trials comparing placebo with radium-223 is it did lengthen the time to the next skeletal event, and then there was a benefit of survival from 11 to 14 months. These folks were given 6 one-monthly injections of the appropriate dose of radium-223. Some of the patients received Taxol, some did not. There doesn't seem to be a difference whether they received Taxol or not. And there are new clinical trials now combining enzalutamide and abiraterone in order to measure the synergistic effect of radium-223. So we've treated this fellow with 800 centigrade times 1 to the bilateral sacroiliac joints in a 4-field plan so that we didn't, so that we kind of spread the dose around. I did see him 2 months after. He was off his fentanyl patch and was just taking an occasional hydrocodone for generalized pain. He had no focal pain at all, and he continues on with Zytiga or enzalutamide. I want to switch gears for a minute, get back to the Truebeam. And this is a wonderful machine that delivers stereotactic radiation, whether it's to lesions in the brain or body stereotactic to anywhere in the body. And the rationale is if we come at the tumor in a bunch of different directions, where all those beams intersect is the high dose region, so we can treat the tumor with a small margin, very small amount of normal tissue will receive the high dose, that we should be able to decrease side effects and increase control, and that clearly has happened. The new machine also has a very high dose rate, so our patients don't have to lie for long periods of time. We can deliver it quickly, accurately, and efficiently. And this is the Truebeam with a cartoon body on the treatment table, and oops, there's my laser. All right. Anyway, this is the treatment head. Then we have imagers. It's called an onboard imager that can either do a cone CT, which is a quick CT scan, so we can look at soft tissue as well as bone to provide alignment. And this machine can rotate 360 degrees about the patient. And this is a cartoon from our treatment plan showing that we're treating an area through 5 different, what we call gantry positions, or 5 different angles. And the doses are varying inside each of those fields so that we can conformally, treat a patient safely. Another cartoon with the cone CT. It's a wide beam and it sweeps, nearly a 360 degrees around the patient. And then it reconstructs a CT image. We have their CT image from their planning, and we do image fusion, and it tells us if the patient is offset. The therapist can use some buttons on the linear accelerator and make all of the tissues and bones line up, and then proceed with treatment. That whole process takes about 3 minutes, 3 to 5 minutes. And this is just another cartoon showing how the gantry sweeps an arc for the cones, for the cone beam CT. So we have the cone CT, but it also can deliver orthogonal radiology quality images for us to line up patients quickly as well. And so it has a high dose rate to deliver the radiation therapy quickly. We also, in certain areas, particularly the lung, we can watch the tumor as it's being treated at the various positions, so that we're sure that the tumor nodule that we're treating is in the treatment field. These patients have to be immobilized. This is our body fix apparatus. So from head to toe, arms, everything is put into position so that patient has to be comfortable. This is an abdominal compression device because we don't want them to take a big breath, particularly if we're treating something in between the pelvis and the thoracic inlet. And so this is what this thing is highly modular, very complex to set up, but it's used specifically for body stereotactic radiation therapy. Now, the new concept is ablative stereotactic radiation therapy, meaning we give such a large dose, we overwhelm all the repair mechanisms of the tumor. We don't care about fractionating it because we know how much, there can be a small rim of normal tissue in the treatment field that will receive the ablative dose as well, but that we know what those volumes are that we can safely treat and not cause symptoms. But the idea is to give 1 to 5 very high dose treatments to that tumor and just overwhelm all repair and ablate the tumor. And for the last 3 to 4 years, we have been performing intracranial stereotactic radiation therapy where we can treat various bone metastases. With this new machine, that to treat one lesion would take about 20 to 30 minutes. Now we can treat a whole lot quicker. I mean, the setup is longer than the actual treatment, and the arcs are delivered much more efficiently. Now, when it comes to brain stereotactic, we know that it's basically based on size. I mean, our control rates go down as the area of metastasis gets bigger. Now, neurosurgical resection of some of these larger tumors and tumors that have traditionally been more radio-resistant, we feel should be, if they can, be resected by the neurosurgeon, and then we would follow that with stereotactic radiation to the tumor cavity because it would provide better control. And as it stands now, we are treating patients with 4 or less metastases with the stereotactic cranial radiation. There's newer techniques to deliver body stereotactic radiation. Right now we use what we call step and shoot, where the machine will rotate at an angle, shoot from that angle, go to 5 to 10 different positions, whatever's needed to get the conformality to treat that metastasis. And the new kit on the block is called Rapid Arc. Instead of the machine stopping and shooting at various angles, it sweeps arcs and it's changing the shape of the beam as it goes so that we can get it can achieve very elegant dose distributions, but more importantly, we can treat a whole lot faster than before. And we're in the process of commissioning the rapid arc therapy to bring it to this institution as well. And we talk about 4-dimensional radiation therapy, and that's when you're tracking a tumor as the body's breathing, for example, tracking a lower lobe lung tumor with breathing. It'll get either treated inside the ventilation cycle, or you can use a breath hold technique or abdominal compression. I mean, there's a whole number of techniques that we can use to treat lung tumors to keep that volume as small as we can and use ablative doses. But I just wanted to spend a little time with that. So the second case is a gentleman diagnosed with non-small cell lung cancer. He's in good performance status, minimal weight loss. He's had his workup of CT of the chest and PET CT and brain MRI. And he's got a lung nodule, solitary nodule in the brain, and a solitary nodule in the liver. And biopsy was performed demonstrating adenocarcinoma from the liver metastasis, and this was presumed to be a lung primary. Now what? In the old days, we would give either whole brain or stereotactic radiation, and then he would receive chemotherapy. Well, the new treatment paradigm is, all right, this gentleman has limited oligometastatic disease in 2 different organs. So why, studies have been ongoing to treat the lung nodule, the liver, and brain metastasis, and then give adjuvant chemotherapy. The idea was to decrease the tumor burden to what we call micrometastatic disease, and rationalizing that the chemotherapy would be more effective in eradicating that and give longer survival, if not a potential for cure in a subset of folks. We know this comes from multiple studies in chemotherapy and in surgery. I'll get to the Mayo Clinic trial in a minute, but the current status is to use the PET scan to measure the tumor burden, so that we have some idea of which patients do we need to pursue this type of approach, which patients should we not do this. And I think it clearly is based on tumor burden, and to reduce all macrometastatic disease to micrometastatic, and then rationalizing that chemotherapy is going to help either cure or at least maintain, provide longer survival. There's some small institutional studies that implicate that very thing. And what's curious here is, these folks had 1 to 5 oligometastasis beside their primary, were treated with stereotactic cranial and stereotactic body radiation therapy, and then received chemotherapy, and we're seeing a number of what we call long-term survivors. And so now this has, because we have these small institutional trials, it's spawned a whole number of national clinical trials to measure that very fact. And so right now it's patients with breast, colorectal, lung, or esophageal cancer with less than 5 areas of oligometastasis, and would receive radiation therapy to all these spots, followed by chemotherapy. There are also a number of trials looking at surgical resection, RFA, as well as other modalities to control micrometastases, to see if this concept works. And so that'll be ongoing. So if Dr. Ottoman was telling me about the guys at the Mayo Clinics were chasing all kinds of, chasing metastasis all over the place, well, now we understand why. It's because they performed a clinical trial to help us define patients with limited oligometastatic disease. So case 3, Dr. Ottoman referred this gentleman to me. He had fulminant colorectal cancer. When I met him, I knew that Dr. Ottoman had treated him as much as he could. He's got chemotherapy refractive liver metastases, and he was very uncomfortable. Couldn't bend, couldn't sit. He was pacing the room because he was in so much pain. And his CT scan showed fulminant liver metastases, so what I proposed that we treat him with 7 treatments of 300 centigrade. This is, to the liver metastases. What was remarkable is on day 3, his pain was a whole lot better. He did die 8 weeks later, but at least he was pain-free. So even some of these traditional palliative radiation therapy regimens are quite effective. We also use whole brain radiation therapy. It's been a tradition for a number of years for patients that have, a multitude of brain metastases. We think that if a patient has 3 or 4, we probably, in selected cases, treat those with cranial stereotactic radiation, just treating each individual lesion. But now we still use the whole brain radiation therapy, and this is her, just one slice of her MRI showing these multiple lesions from her endometrial cancer. And then a repeat MRI at 4 weeks showed that the bulk of this had disappeared. We've got a few residual nodules here that we'll watch. But even traditional, we don't need all this new technology for everything. We still have got to provide some of the basic palliative radiation therapy as well. Spinal cord compression is a problem. When patients present with weakness, numbness, of the lower extremities, we try to get them to the neurosurgeon and see if he's a neurosurgical candidate, because that is the one intervention that will rapidly decompress spinal cord compression. But some of these folks are not in any kind of shape, and if you can understand the treatment algorithm of a neurosurgeon, let me know. But our recent trials have shown us that in reversing neurologic symptoms, one single treatment of 800 centigrade seems to reverse more patients than if we use fractionated radiation therapy or radiation over a week or 2 weeks. Before this clinical trial, a number of institutions were using 600 times 2, and now it's just accepted that 800 times 1 provides good palliation of pain, as well as helping reverse the neurologic symptoms from cord compression. And we would consider using stereotactic spinal radiation therapy. This planning process takes, on the fast track, about 3 to 4 days if it's recurrent in a previous radiation field, and it allows us to treat the cord compression, or we can treat a bone metastasis and avoid the cord in a retreatment area. And that's an active, ongoing area of clinical trials as well. And this is just showing the cord being compressed by a bone metastasis here. And typically we would treat from this level to this level with 800 centigrade times 1. We try to split it over 3 or 4 fields. The new clinical trials, there was a Dutch randomized clinical trial that showed that clearly reversed more neurologic symptoms than fractionated regimens. They looked at 400 times 5, 3 gray times 10, 250 times 15, and 800 times 1 was far better than the other arms. So in conclusion, we've got new technological capability here to provide even sophisticated techniques for palliation. It is my hope that the new body stereotactic clinical trials are still in committee, but a number of them will be released in June, that we can participate in those trials to help us define who we need to be aggressive in treating oligometastatic disease and provide better palliation to our patients. And we're real excited about the radium. It's an intravenous radionuclide that we can inject for pain, but is now, it turns out, is going to be a good therapeutic agent as well. And if we could get the government to get off their caboose and make this available to our patients, I probably get at least 1 or 2 phone calls a week from a medical oncologist, and now I don't even return their calls. No, I'm just kidding. But anyway, so even palliative care is becoming high tech, and shorter treatment times, and a lot less driving for patients, and it saves money. So the government's happy, we're happy, the patient's happy. If we could just get the medical oncologist to be happy, we'd be all right. No, just kidding. Thank you. All right. Any questions? Sir?
Excuse me.
Is this going to change the radiation fibrosis that we'll see around the lungs after you treat somebody for typical lung cancers?
It will, and that's a real problem. Looking at, they're trying to establish new criteria. When you treat a lung nodule or treat a liver nodule and follow them, with CT or PET, it's kind of ambiguous, and we're trying to, and that is a problem, is we can't, figure out who we've controlled, who we haven't controlled, except following with PET scan. But those criteria are being worked out, and that's, I think, one of the difficult things to assess is, we know that over time they do well, and they've gone in and surgically removed these areas, and there was no tumor, but radiologically it can be a nightmare, and we're going to make your life miserable. Any other questions? All right. Thank you very much.
I got one more. I'm curious that that case with the guy with the liver full of mets and he was pacing around the room. How the heck did you get him to sit still for radiation therapy?
That's a good question. I must have good therapists because he was able to lie still. It was the sitting and bending that he was in pain. I think lying still, the pain medications that he had were effective. He just, he couldn't sit. He couldn't, I just think he was able to do that. And, the therapists are used to working with children and, all kinds of folks, and they're very good at getting them to lie still. And I don't know if they bribe them with candy or money but they do a marvelous job. All right. Thank you.